Thank you. Hi, everybody. Good afternoon. I'm so happy to be with you. How are you guys enjoying the conference? Yes? Okay, so what did you guys think about the food? Good choices for lunch? Yes? All right, good. So you guys have to give us feedback on that for the vendors. So I am so proud, honored. Look at my babies. I'm so proud and honored to introduce the Mother Lab. Mother Lab stands for Maternal Outcomes for Translational Health Equity Research. So I started Mother Lab about we're almost 3 years old. Oh my God. 3 years ago in July 2020, at the height of the pandemic, I was giving a lot of talks that spring. I had a lot of talks slated to be given, and then pandemic happened and everything got moved online. And I kept getting these incredible talent. I was like, I want to support what you're doing. How do I get involved? And so that's where Mother Lab came from, just the harnessing of this incredible student-led talent. We are really focused on studying the disparities, eliminating disparities in maternal health care for Black and brown women. And Mother Lab utilizes research, advocacy, and focus on policy and mentorship to really eradicate these inequities by confronting and dismantling the systems that enable and perpetuate racism for Black women who give birth. So today we have a panel of members from the lab to discuss more about their work, and please, they are seasoned presenters by this time. They've done a lot of conferences, and I tell everybody in Mother Lab we should be ready. This mic, can I try another mic? I tell everybody in Mother Lab they should be ready to be on CNN at any given time. That's what we're training for here. We're the largest lab in the country, and at any given time, we can and should be ready to respond to the call. So please welcome our amazing panelists, Suwar Abhula, Subecha Durali, and then Lily Snape. So I'm going to give you guys their bios and be very nice to them in the questions. These are my babies. Okay. Our first panelist is Suwar Abhula. Suwar is a senior at Tufts studying community health, Arabic, and biology on a pre-medicine track. She is the founder and senior advisor of MARCH, Maternal Advocacy and Research for Community Health. The largest, you're using my language, go girl. The largest undergraduate-led maternal health I trained them. I'm so tickled. The largest undergraduate-led maternal health organization in the United States. Incredible. Yes, thank you. Our next panelist is Lily Slape here in the middle. She's a sophomore. And I have to tell this, I just got to embarrass you for a second. Lily started volunteering for the conference last year as a freshman. I was like, how are you helping run the marketing for the largest conference in the world as a freshman? I couldn't even see straight when I was a freshman, and she's like amazing. So thank you, Lily, for all the marketing stuff. Here at Tufts University, major in community health and child studies and human development with a political science minor. She's from Boston, Mass. She joined Mother Lab in August 2022 and is currently working as a co-chair of the Marketing Communications Committee for Mother Lab. So thank you, Lily. And then last but not least, Subecha Durali, my other baby who's about to graduate. I'm not there yet. I can't process because they've been with me since they were like freshmen or sophomore. Like, what do you mean you're graduating? What? What do you mean you want to graduate? I need you here in Mother Lab. All right, I'm going to try to keep it together. Subecha Durali, a fourth-year undergraduate student attending Tufts University studying community health. Subecha aims to pursue an MD, PhD degree to become a physician scientist involved in public and community health, specifically in reproductive and maternal medicine and research. Please welcome our amazing panel today. Thank you.
Hi, everyone. As Dr. Ao introduced us, we're the Mother Lab, and we're going to be talking about the Black maternal health crisis in the United States through the lens of the next generation of maternal health scholars. Sorry. Just before we start our presentation, I wanted to frame the Black maternal health crisis in the United States. So if you look at the data on the screen above, this is the data a few of our presenters have been talking about in the last few presentations, but it is the CDC data that came out on maternal mortality that was released a few weeks ago, and it shows a sharp increase between 2020 and 2021 in maternal mortality. Not only is maternal mortality getting worse in general, but the disparities between racial groups are sharply increasing. It was safer to give birth in the United States in 1980 than it is today, and maternal mortality is only becoming a greater epidemic.
Next is showing how the U.S. compares in other high-income industrialized countries according to the Commonwealth Fund. As if you can see, the U.S. has nearly 24 maternal deaths per 100,000 live births, which is more than 3 times the rate of most other high-income countries. And this is very concerning because this is just 2022 data. So the slide we saw before, this rate has increased even further. One of the reasons that this is because I think this, okay, so this slide is, we are just taking that data and we're looking closer at racial groups. And as you can see on the screen, the U.S. Black population has the highest compared to any other. One of the reasons this is, according to the data, and what we can highlight in accordance to this conference theme, centering the role of nurses and midwives in combating Black maternal health disparities, is the number of providers in maternal health that we have in the U.S. compared to other high-income industrialized countries. When you look at this figure, you can see that we have a total of 15 per 1,000 live births, 11 OBGYNs, and 4 midwives per 1,000 live births. This is outrageous. And if we look at other countries such as Sweden, such as the UK, they have 43 midwives per 1,000 live births. And that's why their maternal mortality rate is 6 compared to our 24 just in 2020. Exactly. It says a lot. And so we're going to talk about our lab, which is centered, as Dr. Ayo said, to combat these disparities through advocacy, through mentorship. And that's why we call our lab the Mother Lab. We are the Maternal Outcomes for Translational Health Equity and Research Lab. We are structured into 3 committees: the Research and Grants Committee, the Community Engagement Policy Committee, as well as the Marketing and Communications Committee. Though our committees all have each individual projects and responsibilities, we always make sure to cross-collaborate between our committees on several projects, as well as terms for collaboration between our committees in order to promote diversity and keep up-to-date information on current maternal health trends. As Dr. Ayo mentioned in the beginning, our mission is to address and eradicate inequities faced by Black populations and birthing people. And our vision is we want a world where BIPOC people, specifically Black birthing people, can go into a hospital, they can give birth, they don't have to feel less than due to systemic racism, due to homophobia, due to white supremacy, and that they feel healthy and secure in the birthing process.
So the Research and Grants Committee really focuses on curating and preparing the next generation of maternal health scholars. And as Subacha stated, we really work kind of across committees, but also within our committee, learn from each other sort of intergenerationally. So we have everyone from undergrads to MDs to PhDs, all collaborating, all learning from one another. And we really focus on applying for grant funding to really support this work, as well as working together on numerous projects, which I'll get into on the next slide. To really kind of, highlight these issues, but also offer suggestions for improving and alleviating these disparities. So some of our most recent projects have focused on maternal mental health, and we've really been looking at the impacts of systemic racism, but also of other socioeconomic factors that really come into play and are really driving these disparities. We are also focusing on really getting to the root cause of a lot of these disparities through the policy lens, which we've seen huge shifts in maternal and reproductive health policy in the U.S. over the past few months even, and really, getting to the historic roots of this, but also understanding what steps we need to take to hopefully improve these outcomes. So we're really excited about these projects and are constantly taking on new ideas and new questions.
The next committee we would like to highlight is the Marketing Communications Committee, which I'm lucky enough to be part of. It's focused on disseminating all information the Mother Lab comes out with, our research, our presentations, blog posts. We have thousands of followers on all our social media. You should follow if you're interested to hear more about our research and our events that we have. In 2022, we had an annual report, as you can see on the screen. So sorry about that. We had an annual report. We reached 1,000 followers on multiple of our social media platforms and got into the couple thousand on Instagram and Twitter. We pushed new research. We had plenty of publications last year, so we got to push that out to the local community. We launched the Nurture Kit initiative, and in the past month, we had an aftershock viewing, which was a great success that we were super excited about.
The Community Engagement Advocacy and Policy Committee are responsible for connecting with community organizations. By community organizations, we mean where our Mother Lab members are based. We're a national lab, so there are a majority in here located in Boston, but there are also many located in Texas, in Tennessee. So any local organizations that our members want to take the initiative and connect with are the role of this committee, as well as keeping up to date on maternal health policy. Next slide, please. Some specific examples of projects that have been done by the Community Engagement Committee are, if you look on the right and left side, are two policy newsletters. Back in early 2022, when there was obviously reproductive health rights issues regarding the reversal of Roe v. Wade, our Community Engagement Committee created a policy newsletter highlighting different case studies that required and basically constitutionally safeguarded the right to abortion as well as other reproductive health measures. And this policy newsletter taught me a lot about the history of reproductive rights in the U.S. And then the one on the my left is about the lack of nutrition in different states in the United States that have food insecurities that are specifically targeting pregnant people of color. In the middle is the initiative Lily talked about, the Nurture Kids initiative, and pictured is one of the committee members, Liz. And on the bottom is the Mother Lab podcast, which currently has 7 episodes led by Ameo, the co-chair of this committee. These podcasts are amazing. They feature Dr. Ao, some of our members of the Mother Lab, and feature also people who are doing the work, such as abortion providers, Dr. Khan and Dr. Lockley from New Mexico and New York City, who are in the midst of facing the repercussions of the Roe v. Wade reversal and Dobbs decision. They also feature lactation specialists, doula providers, the whole set of maternal health is in this podcast, and I highly recommend you listen to it.
And now, my favorite part are all the branch organizations of the Mother Lab, which I think are very unique, and which we'll get into the next slide. So one of them is the Maternal and Child Health Journal Club, which is based here at the Tufts Med campus. And we really focus on really getting well-oriented in the maternal health literature and meet monthly, with different themes each month and each semester. So pictured here are a few guest speakers that we've had. Ave, who presented on her research. We've also had events where, current med students or young researchers are able to really showcase their projects. So we focused on both published research as well as research currently in the works, and highly recommend that you sign up to our e-list to join. We do meet on Zoom, so wherever you are, you can join. Highly recommend.
The next thing we're going to talk about is March, which is an undergraduate club at Tufts University. It's the first undergraduate club at Tufts University focusing on maternal advocacy, and the first club in the country focusing on maternal health advocacy. So it was started by Siwar in 2022. She's amazing. Now she serves as our senior advisor, and Tia from programming and I are co-presidents for March. So essentially what we do is we have weekly meetings where we connect with members of the undergraduate community to talk about current maternal health issues and current statistics in maternal mortality. We work with a local nonprofit called Summer Baby, which is an amazing amazing organization. I recommend looking into it if you haven't heard of it. It's an organization that provides education and a baby basket to every newborn baby in the city of Somerville. So we work with them, do collaboration projects such as putting up posters we design for them to help educate the Somerville community, or doing diaper drives. We also raise awareness for maternal health in our school community through tabling. We have trivia nights. We also do movie screenings like we did for Aftershock last fall. So it's an amazing organization. We're so thankful for CWAR for starting it. And it's a community that I love being a part of, and it's so inspiring to see so many undergraduate students so passionate about maternal health. And it helps me be super optimistic about our future, because I know personally there's like 60 members at Tufts who want to make a difference.
Talking about members of Tufts, this was a course that I started last fall. I got the opportunity to teach a maternal health focused class that first year students signed up for. This was inspired by all of the experiences I've had at the Mother Lab and the Center for Black Maternal Health and Reproductive Justice, as well as any other maternal health experiences, this conference that I've been lucky enough to support and be a part of for the last three years. So this course was kind of a accumulation of everything that I've done in maternal health, and I wanted a way to summarize the biggest problems and figure out solutions with people who probably never heard about the maternal health crisis. And I just loved this course so much. Some final projects I wanted to highlight is one, Our Moms Are Dying graphic. One of my students, Anya, she created a Zine, which is a virtual kind of magazine, where she summarized all of the maternal health statistics and kind of put the maternal health crisis into simple terms, as well as highlighted key terms like maternal morbidity, maternal mortality. And these were kind of ideas that were influenced by her friends and people from the Tufts undergraduate community who had never heard of the crisis. I pictured here is my class basically going to the Designing Motherhood exhibit in Boston, where we were introduced to a lot of aspects of maternal health, maternal mental health, maternal reproductive health, and how it looked throughout the course of American and kind of global history. This influenced two of the students pictured, Remy and Emily, who is part of March, as well as is a volunteer for the conference today, to create a project where they gave the class simulations of different maternal health positions and the positions birthing people are part of. The one that I got was I had to put myself in the shoes of a trans father who is currently pregnant, who wanted to travel approximately 100 miles to receive gender-affirming health care for their pregnancy, or continue to go to a clinic that had not provided this gender-affirming care. And the way they wrote these narratives of people were both fictionalized by them as well as people who they knew. And I thought it was an incredible way to kind of, as someone who's doing the research or doing the advocacy work, to kind of think about, okay, these are the statistics, but these are also real life people, and real life people go through these. And I think this influences all Lily, Siwar, and I to continue doing this work, but everybody in this room as well, just to think about, like, we're personal people. We have people with stories, and it really came back to me that the work that we do is for the people. It's not just for the publications or the research, or conferences like these are great to meet other people, but it's for the people who are going through these issues. Oh, thank you. Some of the future directions for our lab is we hope to continue cross-collaborating between our committees, to continue identifying and disseminating information regarding maternal mortality and morbidity in the U.S. as well as globally. We also hope to continue to incorporate the reproductive justice framework in everything that we do, whether it be conferences like this, publications, or events that we run. And we hope to advocate and continue to advocate in multiple of our platforms, as well as some research to advocate for the expansion of Medicaid to include doula care. As we might have heard in our previous conference revolving around the role of doula care in in combating Black maternal health disparities. Doula care helps. It prevents birthing complications that Black mothers particularly face in general hospitalized settings. And we did a research project last year regarding this, as well as presented this topic at the APHA last year. And we want to continue advocating for this because this will make like a huge, profound policy change. And our last one is really the reason why this lab started. We hope to continue to support and foster maternal health scholars and academics to become health professionals or research professionals in the maternal health field, because this truly will continue throughout the generations, eradicate the maternal health disparities we see today.
And we hope that you stay in touch with us. As Subacha said, this is not the end. This conference is not the end of these discussions and conversations. So please, feel free to contact us, visit our websites, and on the following slide, we have our different social media platforms. So please feel free to connect to stay up to date. And thank you so much for listening to us today.
Does anyone have any questions for us?
Thank you, Mother Lab. That was amazing. Can you talk about the Nurture Kits initiative that we're currently raising funds for? Thank you.
Yes, great question. We would love to. So the Nurture Kits are, self-explanatory. They're kits that provide really essential resources to mothers and really high-quality resources as well. So everything from breast pumps to diapers to baby essentials and necessities. And we're really hoping to fundraise to provide these kits to really provide these essential resources that are also sustainable and last long. So, for example, with the pumps, really reusable and can be, make a huge difference in the lives of these new parents and new families. So we really recommend that you support us in this initiative. It's not over. We're trying to fundraise, I believe, approximately $20,000 for these kits. So any dent that we can make in that would be amazing. So we really would appreciate your support.
Thank you. And did you say that there's a QR code on the back of the program? Wow. Oh, wonderful. Thank you so much.
Yes, so we have a question from the virtual audience. One was, how do you recommend universities develop a program like March or Mother Lab?
That is a great question. And that's one that we really reflect on at March, because it is a huge undertaking, and we're so grateful to have faculty like Dr. Ayo, like the Mother Lab, that are able to support us. We believe the first step is to simply find people with a passion to make a difference in maternal health outcomes. So you don't need 3 to 4 committees or 60 plus members, or really, a huge sum of funding to do this work. All you need are a couple students who are interested and a local group, or a local project that you can take on. So with Summer Baby, for example, Summer Baby is through Somerville Public Schools, and they provide resources to new parents, but also English language support to immigrants in the area, and all these other supports that may not be maternal health related directly, but that certainly impact mothers and parents. So I believe that, the first step is to find an audience, find people who would like to help you out, and then find a gap and fill it. And it's great to have resources like the Tufts Med Campus and the Mother Lab, but if you don't, that's totally fine. You can still do this work, and also our doors are open as well. We'd love to support you. So if you're a student out there and would like to do something similar, please message us on Instagram, please reach out, and we'd be more than happy to collaborate with you as well.
Amazing job, you guys. So proud. Can you just give us a little bit more, could you provide a little bit more data about the numbers you're getting on social media and how they're trending? And also, what is aftershock? You mentioned aftershock, and I wonder if that's something you could explain.
I'll start with the social media question. So our lab was founded in 2020. So since then, we've had a sharp increase in followers. Specifically last year, we had a huge boom in social media and for people visiting our websites and other publications. Sorry, I think last year alone, we had around 25,000 views on our website, which is super exciting. And I think we gained around 1,000 followers on Instagram last year as well. So we've had a big increase, especially since we started, and it's only growing faster and faster as time goes on. And then our Aftershock screening. Aftershock is a documentary that follows the lives of families affected with maternal mortality, Black families affected by maternal mortality in the United States. So it interviews many families. You get to see the personal lives, the aftershock of the maternal mortality. So we had a screening for that in February.
You can watch it on Hulu. It's still available on Hulu, which is a media platform, yes.
Yes.
Hi, everybody. My name is Jay Wilson. I'm the founder of Melanated Moms. I wanted to know, how can other community-based organizations be involved or participate in some of the work that you all are doing?
On our website, we have a form, which is get involved with us, or if you go on our website, it says contact us. There is a specific form that the Community Engagement Committee created to branch out to other community organizations that are interested in working with the lab, specifically with the committee. There's a form and there's kind of questions that highlight what kind of projects you would want to do or what kind of work that we can support your organization in. So that would be the number one way.
And I'll add to that briefly. Also, the Research and Grants Committee is always looking for communities to support if they need research support, which we understand sometimes can be a huge undertaking with dealing with data, understanding the data, knowing what to do with it. So we also support organizations in that. So to that end as well, feel free to reach out to Research and Grants, and we'd be more than happy to support with any data collection that would be helpful to your organization, or if you have the data, what to do with it.
And with marketing as well. With marketing as well, we love to hear from community organizations. We have a blog on our website. Right now we're working with a smaller lab at the University of Maryland, and we're doing a little spotlight on them. So we'd love to talk about organizations working towards this cause as well. And we would also always welcome collaborations on social media, whether that be live streams, posts we're collaborating with. We'll share things your community program is doing. So really reach out to anyone, and we'd love to work you.
I believe there's also an email specifically, since the Mother Lab is now housed in the Center for Black Maternal Health and Reproductive Justice. It's blackmaternalhealth@tufts.edu. Thank you.
Good afternoon, everyone. My name is Lily Schneider. I'm happy to introduce our two next concurrent sessions. So I'm going to give a long speech, and then you can decide if you want to stay here with us for this next panel or go to another room where Dr. Moore will be giving a presentation. So I'm happy to introduce our next two sessions, first of which is our fourth panel entitled Holding Space and Sharing Our Stories, Black and Indigenous Community Members on the Joys and Hardships of Rural Maternal Care, moderated by Ms. Stephanie Crawford. Stephanie is a Boston Public School early childhood teacher with a master's degree from Lesley University in moderate disabilities. She is currently in the Early Childhood Leadership Policy and Finance doctoral program at UMass Boston. Stephanie owns Beljois Doula and Family Services and is an active community organizer, trainer, advocate, and consultant, and an absolute joy to work with because I get to work with her most days. She was recently honored as a community trailblazer for her foundation, Propacity Community Outreach, by the City of Boston, specifically the Mayor's Office of Women's Advancement, for her work in grief support and community birth work. Stephanie will be moderating a conversation here with Nicole Gonzalez, who serves as a Diné nurse midwife from the Navajo Nation, who grew up in the four corners of New Mexico and currently resides in Albuquerque, New Mexico. She is an Indigenous feminist, published author, inspirational speaker, grant writer, and freelance consultant. She has advocated for improving Native American maternal and reproductive health both nationally and globally. She is well known as the founder of the Changing Women Initiative, a Native American women-led organization intending to reclaim Indigenous birthing practices while supporting the return of Indigenous midwifery in Native American communities. And then in room B09, Dr. Lavonne M. Moore will lead a discussion centering clinical matters of Black birth. Dr. Moore has a Doctor of Nursing practice from St. Catherine University, a Master of Science in Nurse Midwifery from the University of Minnesota, and a Master of Arts in Health and Human Services Administration from St. Mary's University. She is a certified nurse midwife, certified women's healthcare nurse practitioner, international board certified lactation consultant, and a certified childbirth educator. So we'll give you guys about 5 minutes to either settle in here or head down to the other room, and we welcome everyone to their respective stages. Thank you.
Exactly what I did. Now we're together and I can't wait to start the rest of our lives here. So will you take me and will you make me the happiest man in the world? Say, can I take you and can I make you? Can I make you my forever girl? I can't explain how you make me feel, but I can show you anytime that you like. I was nervous, but I know that it's real, and I know because it feels right. You're the one my mama told me would be waiting when I'm ready, and I ain't gonna lie, I didn't believe, but she was right and I was wrong, and now you're here and we're alone, and baby, that's alright with me. So will you take me, and will you make me
Once again, back to the stage is Nicole Gonzalez and Stephanie Crawford. Thank you so much.
Hello, everyone. Thank you for being here. I'm so excited right now to be here having this conversation with you. I feel like I'm going to learn so much. And so I would love for you to introduce yourself, and then we can talk.
Hi, everybody. Yat'e. I'm Nicole Gonzalez. She'e Nicole Gonzalez nishe. Glashchi'in nishlento, tochi'ni bashichin, ashgai soy deshache, nanasteja deshanale. In my Navajo tribe, we're matrilineal, so when I introduce myself, I introduce my mother's matrilineal line and our ancestryship. And so when I introduce myself, I bring my ancestors into this space because they're always with me and travel with me. So thank you.
Thank you. So I'd love to just start around the history of Indigenous midwifery care. So if you could talk a little bit about that and some of the examples of Indigenous frameworks regarding birth and motherhood.
Yeah, Indigenous midwives or Native American midwives have been in the United States or Turtle Island a long time. Unfortunately, during the 1950s, when the colonization of birth happened within our tribal communities, Indian Health Services came, and a lot of the births transitioned from our home setting into a hospital setting. And so a lot of like how the granny midwives, a lot of our Indigenous midwives have, been pushed out, either illegally for not being able to practice without a license, or have gone underground and practice more in a ceremonial capacity. So in New Mexico, where I'm from, some of the Pueblo tribes still have traditional midwives who attend births in their tribal community as more of a ceremonial person. So they don't order labs, they don't oversee the heartbeat of the baby. They basically pray, and they're in this ceremonial relationship with women during birth and pregnancy and postpartum. And so they're still around. In my Dene culture, we used to have traditional midwives who attended births in hogans or in like our summer hut houses. And to be a Dene birth worker or a midwife, you were considered a medicine woman. And so when babies were brought into the world, we were the first to acknowledge them as a medicine person. And we had ceremonial practices around welcoming baby into this world. A lot of the births happened in our hogan settings, which is our home. So if you ever go into the Navajo Nation, there's like these round homes that we lived in and had ceremony in, and on one side of the hogan is where the women would birth and have their babies, and usually are attended by a medicine woman or a midwife. And so because we recognize water and blood are sacred and living things, oftentimes the medicine midwife would have to be from a line of traditional medicine midwives. And so like the Water Clan would be something that maybe a traditional midwife is from, which I'm from. I have my own lineage of traditional midwifery in my bloodlines as well. They also performed coming of age ceremonies. So a lot of, because our tribes are matrilineal, women had coming of age ceremonies when they came into puberty, had their first period. So they were there overseeing women come into their womanhood as they got their first period. So traditionally, our Indigenous midwives on Dene communities held many titles and roles, were very, very well respected in our communities. And so this very clinical side that I actually have to practice in because of my licensing and background is kind of interferes oftentimes with the traditional sides of midwifery that I would love to practice in. And there's also herbs that we recommend women take during pregnancy and during labor. And there's a ceremonial 4-day staying in period after birth. It really mimics our ceremonies. We're very lucky in the Southwest to have our medicine people alive and well and still practicing. A lot of them I go to for my own health, but women also use them during childbirth or prior to having their babies. They have what's called a blessing wag ceremony. And so oftentimes the birth team would go with them to this blessing way ceremony to prepare for birth. And I often see, I get a little frustrated that blessing way has been co-opted and is like this kind of thing that people pay for now. But blessing way ceremony for us is a rebalancing of feminine energy because we come into so many types of energy while we're pregnant, and all of that goes into our body and goes into our babies. And so rebalancing the energy for us prior to birth is like having positive thinking that things are going to go well. And so our traditional midwives are actually part of that process for them. Oftentimes tribes in, especially in the Southwest, we didn't ever always have a traditional midwife available. If you were lucky, you had one. But oftentimes it was like a mother or grandmother attending a birth, or a sister or a sibling attending a birth. And as I've traveled across the United States and Guatemala and also in Canada, they have a lot of traditional midwives still practicing in their communities, and they're still among us. They're still practicing. They might not be here in these kinds of spaces, but they are still practicing in our communities. And so it's not like they're gone and they're absent. It's just they're choosing to work in a way with birth and pregnancy in their community as a spiritual leader, as a medicine person, and not a clinician the way we would practice. And so I think it's important to know the distinction. I know in Hawaii right now, I was just there recently supporting those Indigenous midwives to continue to practice in their community. And they lost their ability by July 31st to practice in their community. They'll be illegal because they're not CPMs. I think the challenge when we talk about Indigenous midwifery is a lot of people understand indigeneity as like looking like me, right? I look brown. I'm Dene. I have my tribal papers, but there's a lot of in-betweens, right? I actually looked up the information for this state, and there's 2 federally recognized tribes in this state. And I know across the United States, there's over 500 federally recognized tribes, but the government gave us that distinction. So that doesn't mean that I'm Indigenous. I'm only Indigenous because the tribe is telling me, or at least the government is saying, you have papers to say I have lineage, 100% Dene, right? And it's unfortunate because of colonization that the U.S. government gets to decide who's Indigenous and who isn't. And it's a problem. I also know there's a large group of Black Indigenous folks, and like they're left out oftentimes from our resources that our government has made treaty agreements with our tribes. And so I think the discussion or the question that gets asked of me all the time is like defining indigeneity. And it's a problem. I think when we talk about resources and how they get divided up, could be an issue. Unfortunately, we talk about racism, which is an issue we address or deal with across the board. Our tribes also deal with a lot of internalized racism. Like right now, there's a pretendian movement going on where people are outing fake Indians and really going after them. It's really sad to see that happen in our communities because our ancestors, our grandmothers were never like that. They always welcomed people into our homes. They welcomed anyone into our community. They taught us to welcome and be welcoming. And so to suddenly have this race war happening within our tribal systems now is really a reflection of internalized racism that we talk about, because now we're starting to use blood quantum and papers to show if we're really Native American or not. And also understand that Native American, the word, is a U.S. government term to define us who are federally recognized. Indigenous is a whole other term, can also be maybe a label that people use who live maybe in the Southwest or over the border. And I think that can be confusing because I often will say Native American Indigenous because I'm incorporating 2 groups. If you go up to Canada, they like to be called Aboriginal. And so I think they're making a shift to Indigenous as well. And so there's a lot of interesting political context around our identity. And we often find ourselves at the front lines of conflict when it comes to Indigenous issues, and especially around birth. Because right now, there's probably less than 1% of Native American Indigenous midwives in the United States right now. And especially as I look across the room, and I'm like the only one here, I don't know who's also Native Indigenous. Can I see your hands? 1? Yeah. Just to give you an example, right? Like oftentimes I go to spaces and I'm the only Native Indigenous person in that space. And so it's a lot of pressure to hold my ancestors and this history in a space where people are trying to understand this really interesting political relationship we have with the U.S. government. Since time immemorial, it feels like, because as we try to reclaim birth in our communities, we're coming up against this treaty agreement with the U.S. government just to have birth in our community. And so when I talk about the history of Indigenous birth and midwifery, like, yes, there's this colonization of hospitals, there's this medicalization of birth, which we all talk about, right? When I became a nurse midwife, I didn't think about all of the hurdles I'd have to overcome just to do this work, and not realizing like the political fight I was going to constantly be in, not only with the U.S. government, but also our affiliate, our bodies of like ACNM and National Academy of Midwifery, like these governing bodies who license us, also have a say in how we practice and where we practice and who has the skills. And in the end, when you travel to other countries, it's like you just want people to have the skills to attend births, right? And yet we find ourselves in this odd position where we start to dictate who can have access to those skills. And I run up against that all the time. People misunderstand what certification means, even as we try to certify doulas, right? I have to explain to people like, well, certification means maybe they took a training, but there's nobody regulating them. And so I have to be careful with the language. And so talking about the history of traditional Indigenous midwifery in the United States, we're still here. We're still providing service and care in our community in whatever capacity we have the ability to. There still is the risk of being thrown in jail for practicing midwifery or even using that term outside of the context that we did not create and define for ourselves. Somebody from someplace else defined it for us. And so those are just real things that are happening.
Thank you. I hear you talking about the barriers like resources, racism, politics, almost like a forced isolation. And I was wondering, have you ever found any other difficulties using Western medicine practices while trying to honor traditional Indigenous practices?
Absolutely. What is always an issue is traditional medicine, and a lot of us probably still practice our own traditional medicines, and maybe some of us don't, but time. Right? When you go see a midwife, it's like 15 minutes, 30 minutes, an hour, you get a treatment, you go home. Traditional medicine doesn't acknowledge time, right? If you're going to spend time with a healer, you're going to spend all night. For Navajos, it's like an all night singing. You're sitting up in a hogan and you're praying, and the medicine person is praying over you. You're doing things. I grew up in a peyote way. My family, my dad's a roadman, and so we would sit in a teepee and we'd pray and we'd have peyote. All night, like you're sitting there all night on the ground, from 9 p.m. to 9 a.m. And so it's exhausting, it's painful, it's a sacrifice, right? And so when you go get traditional healing and you spend time with a medicine person, you as the patient is saying to this medicine person, I need help, I'm going to you show up, right? It's on you to show up. What I find as I'm trying to provide midwifery care with a traditional context to my own community is they're thinking I'm a doctor or a midwife in a clinic, so I have to call them and be like, remember, you need to come to your appointment. Remember, you need to come see me. And then they're getting mad because I'm not following up with them. But it's like, if you're thinking in a traditional context and you're going to see your medicine person, they don't call you to go see your medicine person. You show up. And so there's a misunderstanding of roles and accountability from the person who's getting the care and receiving the care and the person who's giving it. But also as a traditional midwife, if you're going to someone to offer support or you want them to be at your birth, right, there's protocols to follow, right? It's not an exchange of money. The protocols is you bring tobacco or you bring some sort of medicine or a cornmeal, and you go with your hands and you say, please, I would love for you to attend my birth. And you make an agreement to form a relationship to be at this birth. And so when you go see a midwife in an office, the agreements are different, right? There's informed consent paperwork. There's a time frame. You have to explain the process to them. And so it's really challenging to understand the different ways to provide care to a community who's used to getting care in a hospital setting, in a sterile environment, with a 15-minute window with a healthcare provider, and the hospital and the provider takes all the accountability for care. And that's not what happens when you're with a traditional midwife or even in an out-of-hospital system setup. So people need to be trained and encouraged and educated on how this way looks, which when we talk about informed consent, like imagine a community of people who've never had that. For 50 years, don't know what informed consent is. So they come into you expecting you to tell them what to do. And you're like, well, I'm not here to tell you what to do. I'm here to guide you, inform you. You're going to make this a decision. You're going to be accountable. And unfortunately, that is a challenging place to be because sometimes people don't show up. Sometimes people aren't going to be accountable for their care. And I understand the role trauma plays in our community and even as a healthcare provider, but it's not an excuse not to show up for ourselves. And so that's something that's hard to translate sometimes to a community who's just kind of figuring out how to receive care that's based on their human rights as human beings, based on their cultural values, because you're re-educating them on something they've not ever had before.
Thank you for sharing. As I'm listening to you talk, I'm hearing parallels among Black and Native American birthing people, but I wanted to hear you talk a little bit about that.
Yeah, there's so many parallels. I feel like the struggles that we face as Black Indigenous people in the birth world around respect is an issue, as well as like, how would I say, the structural racism we come up against in our work every day, right? So like, I like to use my nonprofit as an example, right? I've been a midwife for 10 years. I've been a nurse for 17 years. I had to start a nonprofit to serve my community, right? Raise thousands of dollars, start a nonprofit, deal with nonprofit BS that we all know comes with nonprofit. Right? Like just to be in the spaces to be heard, I've had to spend 10 years of my life to get this credential as a CNM for people to take me seriously, right? How much money is that? It's a lot of money. And so when I think about the challenges that we're all facing in our community around respect, those are the same issues that our women in the birthing spaces also face, right? We know that they're not heard and they're not respected, and that they need support and guidance to navigate the system that we're all very familiar with. And so understanding what advocacy means, I think sometimes there's a lot of confusion about what advocacy means. And I say it's confusing because we know our community deserves the respect, right? Deserves to be respected, to be heard. And it makes us angry when they're not. And so when we advocate for them through the system, we want to protect them, but like we also can't enable them either, which there's a fine line there. And so advocating for them in the systems, like I see so many Black maternal health advocates in this space right now. You guys are all advocating for your community, just being here and telling your story, but then you have to go back to your community and revitalize them by who and what you heard here, because they need to hear those positive experiences of others doing this work. I think that's a parallel. I think the struggle with our internalized trauma from how we grew up in our community is reflected in our work every day. Like I can't tell you how many, the more I talk to midwives who were the caregivers in their family. Can I get a raise of the hands of who was caregiver in their family? Who took care of everybody else, right? So what happens when we take care of other people? We get a positive relationship with taking care of somebody, and then we become a caretaker for everybody else. So that's a trauma actually response to suddenly be responsible for so much. And so many of us go into this role of midwives that our trauma is reflected in the work that we do and how we do our work. And oftentimes we don't take care of ourselves. And so I also learned so much from my Black sisters. Like you guys, you all like have such a great community of support. I mean, look at this room. I would love to one day see a room with more Indigenous folks in it, that there is a level of solidarity, that we can actually work together and not let our trauma trip us up from being in collaboration with each other. And so I feel like there's a lot of parallels, not just in our health outcomes, but in our solidarity and how we work together and learn from each other. And I've learned so much from you all.
Thank you. So I want to talk a little bit about maternal care deserts and that being a real issue in the rural or Indigenous experience. Can you talk about how that experience differs from other experiences?
So I know there was a March of Dimes report that just came out about increased healthcare deserts showing up in the United States. Because I'm from the Southwest, that's usually my point of context, but because the Indian Health Services provides the majority of our health care, and there's a tribal and a U.S. government treaty obligation for how that's funded, a lot of the Indian Health Services don't provide birth services. So they might provide prenatal care, but a Native American woman could maybe not go there to have her baby. She'd have to go someplace else. And so if she's living in a community where there's one hospital that maybe attends births or has a birthing unit in a rural area, maybe they're not well funded, they close their labor and delivery, and then now they have to travel further. A lot of the women we serve in New Mexico travel more than 30 minutes, sometimes up to an hour and a half to get care to have their babies. And so right now in Albuquerque, that's where I'm located, north of Albuquerque, Santa Fe, it's like an hour and a half hour drive. The Indian Health Services Hospital does not have a birthing suite or birthing unit at all. So women there might be able to get care as prenatally and then they transfer. Phoenix Indian Medical Center, which serves a large population of urban natives, closed their labor and delivery suddenly last year or the year before, I believe. And so those women also have to travel a longer distance and navigate a more complex healthcare system to get care. I believe in New Mexico, there's only one Indian Health Service up in the Four Corners, Shiprock area that still provides birth services. Other than that, the whole state doesn't have an IHS that attends births. So what happens is Native women are signed up for Medicaid. At some point, they're in their care, and then they get to go to a private hospital close by. And having worked as a nurse in a rural hospital, some of the challenges that we face working in a rural hospital is we're required to do many jobs as a nurse. As a rural healthcare provider, because I did provide midwifery care in a small town with an OB doctor, you're on call every day, and then you have 4 days of clinic, and then you help with surgery, and then you might have somebody in labor, so you go home, you take a shower, and you go back to work, and you're up another full day. I did that a lot. And so imagine who wants to work in a place like that, right? It doesn't attract midwives or doctors who don't want to be on call all that much. And so that's one reason we have a healthcare desert, is because healthcare providers don't want to work in a place where they're on call most of the month and they can't leave. Two, majority of our state in New Mexico is Medicaid insured women. And so we know in our state, Medicaid covers like $1,500 for all of prenatal care. And so if we are a poor state and a lot of our community doesn't have the means to pay for women's health care or birth services, the people who take care of you also don't have the means to run a business or to keep a unit open. I was recently part of listening to a presentation with Project Echo, and they did a survey of some of the hospitals that closed their labor and delivery in New Mexico, and one of they weren't getting well funded. I think they were like $800,000 to $1 million short because of they're trying to keep their labor and delivery open. And so there is it is necessary to improve Medicaid reimbursement, not just for midwifery or for anybody, but so our hospitals can also continue to keep their labor and delivery in rural areas open as well. So I'm a big proponent of incentives for keeping those places open, as well as incentivizing midwives who do provide care in these healthcare deserts. The other thing I don't see happening is CPMs being incentivized to take care of people in rural settings, which I find very interesting because a lot of their work is to work in low resource areas and they have the skill sets to do it. So why are we not incentivizing them to be and work in these rural settings? I often don't hear them as also part of a plan to improve maternal health. They talk about midwives, but they talk about nurse midwives. They're not always talking about CPMs. But also, like traditional birth attendants or traditional midwives could also be part of that process in improving healthcare deserts. So there's lots of reasons that they're present in our communities: underfunding, not well staffed, nursing staff is being an issue as well. As Changing Women Initiative, my organization is in New Mexico. We cover a wide area, so we probably work with 5 or 6 different hospitals. If we transfer to a rural hospital, some questions I have to ask is, do you have enough blood product if I have somebody who needs it? What's the mode of transportation to the main hospital? Is it fixed wing or helicopter? Do you have enough nursing staff to take in another client or a patient coming in from an outside home birth setting? Do you have a consent process that if there's a complaint or something that doesn't work well, that this family can have their due process and be heard? Those are things that I think about in transferring anybody to any hospital in these rural settings. And oftentimes, because they don't have a labor and delivery, then we have to travel further as well.
Hearing you talk, I think about how easy it is to take certain things for granted. I live at least 10 to 12 minutes away from 3 birthing hospitals. And I remember having my son and feeling frustrated that it could be any person delivering him, and hearing you talk makes me kind of come back centered. So thank you for mentioning that. You talked about statistics a bit, and I wanted to bring up that in 2020 to 2021, mortality rates doubled among Native American and Alaska Native women who were pregnant or had given birth within the previous year, according to a study published in March by Obstetrics and Gynecology. So can you share your perspective on how COVID affected Native American mothers and midwifery care?
So the interesting thing with the tribes, because they're sovereign nations, they have a plan for emergency. They have an emergency plan if a tsunami hits, which is not going to likely happen where we live, a forest fire or a flood or something. They did not have a plan for a pandemic. So they had to create one really quick. And who got left out? Pregnant moms, pregnant women got left out of that plan. So that's an issue, for one. The Indian Health Services became full of COVID patients, and so what happened is if you weren't in need of care, it was a top emergency, you didn't get an appointment, or they didn't see you, or they pushed you off someplace else. And so a lot of the hospitals or the care places that you could go, you had to make an appointment, or it was like 6 weeks away, or they never called you back, or you had to figure out some way to get care. And so the other thing is, because there's tribal nations that could open or close their borders to outsiders, they close their borders to outsiders. And there were weeks at times where the tribal members couldn't leave their tribal nation to go get care someplace else for a period of time out of protection of keeping COVID out of their community. And so part of the issue with that is that if they needed to leave, they couldn't leave. If you needed to come in and you're a healthcare provider, you had to get approval from their government to enter the tribal sovereign land to provide service and care, which we did. So we always had to have badges that we were allowed to go onto their tribes. Also, I know there's lots of conflicting at the time concern about vaccinations. We were all forced to get vaccinated, which is not an issue, but when you're working in a sovereign nation, you don't also want to bring in germs, which could affect them. And so being really clear that all of our staff are vaccinated. So there's a lot of workarounds. But when you close services, people have to travel longer distances. They're not sure where to go for care. Your tribe's closing their borders. They're not prioritizing maternal health. You're going to see numbers like that. I know for us right now, a lot of our Native American women experience higher rates of postpartum or preeclampsia and pregnancy-induced hypertension. And we're transferring a lot of people between 32 weeks and 39 weeks because this is like, it's abnormal to see so many sick people now.
Can you talk about anything that's being done to rectify some of the issues that have been experienced, or is there anything being done?
Well, I'm like, what is being done? I'm a little frustrated with what's being done. I traveled to the United Nations in Geneva last fall to bring up the issues of maternal health access for Native people during their session because it was the third hearing, and then I saw the White House blueprints being out, and then I saw there's another set of recommendations made to Human Health and Services by Native American people. So there's all these recommendations coming down from the top down, and nothing's changing. So the interesting thing for me is like what needs to change is hospitals need to be held accountable for one. Right? They get to decide if they work with midwives or not. There's no incentive for them to work with us. Like, we should incentivize it. We should enforce it. If we're talking about anti-racism work being implemented in hospitals, then how are we going to hold them accountable? It has to be attached to money somehow. Same with insurance reimbursement, right? Like, how are we incentivizing insurance reimbursement for those of us who are trying to provide care in these healthcare deserts or in these areas that nobody wants to work? Like, that's not happening, and it should. And also working with our teams. Like, I see a lot of research on what MCHs or like hospitals and clinics are doing to address maternal health, but they're leaving out like doulas and home health workers and midwives who attend births at home and birth centers, right? So there's a whole group of data that is missing from this picture. There's only half of that that's being talked about. On the tribal side, maternal health is still not a priority. I just went to a New Mexico Department of Health event tabling in New Mexico, and maternal health was listed under behavioral health. And so myself and my board president were there, and everybody was like, we didn't think about maternal health. We were the only ones there talking about maternal health. And so I would love to create some sort of policy toolkit or advocacy toolkit to take to tribes to inform them about maternal health care in their communities. I often go to clinics that are 638s, which basically, again, it's a designation for tribes to use their own healthcare dollars to take care of their own people. They have, like, it's interesting, they have behavioral health, they have, primary health care, diabetes care, but there's no women's health, and there's no birth services. And I keep asking them, like, why don't you have a women's health service, or why don't you have a birth services here? And they don't think about that, which is interesting because I often hear our Native men say, we love our Native women and we protect them and we honor them, but there's no services that are specifically for us. And so needing to inform tribes about our increasing maternal health crisis with Native women dying in childbirth, around childbirth, like that's something I talk to tribes about all the time. Helping them understand the landscape of maternal health. So what kind of services are available in their community? They don't always know. They usually have like an advisor who like has some knowledge of healthcare in their community, but they're not always well informed about maternal health. And so I think one of the challenges I hear with people trying to work with tribes is like, who's in charge? Who do we talk to? And because tribes councils change every year to 2 years, it's like the people that you might have had a relationship with, are maybe a different person the next year. And so that can be a challenge. And so, no, it's not being addressed. That's my short answer and my long answer.
Thank you for sharing. You talked about some of the barriers around transportation and getting care, like from your home and being able to get to a place of care. So can you talk specifically about how your organization is addressing transportation issues and utilizing like telehealth and nurse home visiting?
Right. So I work with a licensed midwife and a certified professional midwife, and so they're trained to go into homes and to do prenatal visits. So we do that. So on Mondays, they go west to Gallup, which is an hour and a half to 2 hours from Albuquerque, sometimes 3 hours. On Tuesdays, they go to Santa Fe, which is an hour north. And so we cluster people and we do visits with them in their home. If somebody consistently doesn't show up for appointments, we make an effort to go to their house if it's a transportation issue. And so there's a lot of flexibility on working with them and making sure we get to them, which actually improves this access issue. But we're a small organization. And so I can only imagine if we worked with all the CPMs and all the LMs to do home visits and to see clients and patients so that if they can't come in, they're gonna get seen regardless. But like, who's doing that? I don't understand why people can't do that. It's not that hard. When people talk about money, I'm just like, no, you guys have the money to do this. You just need to refocus where that money's going to go.
Yeah, for sure. I could personally ask you questions all day, but I want to leave some time to see if there's any questions from the audience.
Okay, I'll repeat it. It sounds as though from you sharing that Indigenous women are facing the exact same challenges as BIPOC women in this country, and we recognize through history there are great intersections of our cultures, and we share some of the same lineages, particularly throughout our history of enslavement and the integration of these systems that are harming us even now. Do you feel that if there was a merging of support and camaraderie, or a greater presence of camaraderie against with the Indigenous women and BIPOC women, do you feel that that would help to change the landscape of birth justice in this country?
Absolutely. Solidarity, we know there's power in numbers. I want to add to that is that the educational pathways for midwifery also are very different for Indigenous women. So I'm going to give Hawaii as an example because they just passed licensure that they have to become CPMs to practice in their community. But how many CPMs are on the islands of Maui and the other places that can take a student? And so if they can't take a student, then where do they go for training? Right? So there's that. I'm a nurse midwife. A lot of us are nurse midwives. It's 8 to 10 years of education. I had to leave my community to get my education. I moved to Chinle, Arizona for about 3 months for my last rotation to catch babies. I had to leave my family to get my education. And so if we're talking about Indigenous women becoming midwives, the bar is really high. And so if we could provide skills and knowledge to them based on what kind of resources are actually available to them, maybe we'd have more Indigenous midwives instead of setting the bar higher, because I think about our capacity to do this work, right? A lot of us have a lot of capacity. We have supportive families, we have water, we have housing, we have support systems in place. So we can function at a higher level than most people. So the people we want in these communities to become midwives don't have a lot of those things, right? Right now in the Navajo Nation, a lot of homes don't have running water. They don't have indoor plumbing. They don't have electricity. And so how are we supposed to require people to show up to class, have a vehicle, even internet access? Like that's an issue. Like during COVID, I don't know if you guys saw pictures of kids like around a grocery store somewhere working on their computers because they had internet there, right? And so I think as we revision midwifery education for all people, right, when we make it accessible to the most vulnerable people, we do make it accessible to everybody. And so if we don't have people advocating for us who understand our communities, that these are barriers that we have nothing to do with, but they're keeping us from providing care in our community, like how do we work with each other so that they can get the skills and knowledge to be in community to provide birth services for, like, at I guess, an agreed upon level of safety. Having been in the community as a midwife, the accountability from the community side as a midwife is so much higher than being in the hospital. Like, if my community is going to talk about me not being a safe person to birth with, they're not going to come to me. Right? If I'm not falling in line with traditional protocols, I'm going to get called in by my tribe and my elders, like, what's going on? You're not upholding yourself in a way that aligns with how we want you to be. Right? Like, that's harsh. Like, that's scary. And also, like, people will come at you with pitchforks if you do something that you're not supposed to, right? It's not hush hush in the hospital, you know, we're going to have a side meeting and try to correct this. They come for you. And so, like, when we talk about accountability and those serving in community, using the midwifery education and skill sets to do that, there is already an accountability process in place. We're just not acknowledging that. And so if we lift them up and give them skills to continue to practice in their community, like in Maui right now, their labor and delivery is not going to provide services anymore after August. The traditional midwives on that island are outlined after July 1st. So where are those women going to go for care? Right? We could have worked with them to provide care, but what did we do? We protected the license of midwifery instead. So what is the real goal of intention for what we're doing, right? I think we lose track of, like, our communities and what they need and how we can work with them. And so that's what I'm about. And so I would love to partner with folks to revision ways to train Indigenous midwives. I think we need more of them. But also, they're going to do direct entry methods. They're going to do apprenticeship methods. They're not likely to do a nurse midwifery track because it's out of reach, too expensive, and too far away.
Well, thank you for sharing with us. I learned so much, and I hope everyone else did. And I just thank you for being so open and honest with us.
Yeah, thank you, everybody.
So we're going to allow some time for our brothers and sisters downstairs to come back up for our next session. So we'll take a brief break.
right now. Somewhere in the world, the sun shines right now. Are you ready?
everyone. If you could take your seats, we're going to start the next session.
Hi, good afternoon. I hope everyone enjoyed the last session as much as I did. My name is Perry Barrist. I'm a part of March, and I am so happy to introduce our 5th panel today, titled Disrupting the System, Addressing the Broken Medical Structure Impacting Black Birthing People, moderated by Dr. Monica R. McElmore. Dr. McElmore is a tenured Child, Family, and Population Health Department professor and the interim director for the Center for Anti-Racism in Nursing at the University of Washington School of Nursing. Prior to her arrival at the University of Washington, she was a tenured associate professor at the University of California, San Francisco, and was named the Thelma Shobe Endowed Chair in 2021. She retired from clinical practice as a public health and staff nurse after a 28-year clinical nursing career in 2019. However, she continues to provide COVID-19 and flu vaccines. Dr. McElmore's program of research is focused on understanding reproductive health and justice. To date, she has 94 peer-reviewed articles, op-eds, and commentaries. Her work has also appeared in publications such as Dame Magazine, Politico, ProPublica, NPR, and she made a voice appearance in Terrence Nance's HBO series, Random Acts of Flyness. She is the recipient of numerous awards and currently serves as chair for the Sexual and Reproductive Health section of the American Public Health Association. She was inducted as a fellow of the American Academy of Nursing in 2019 and became the editor-in-chief of Health Equity Journal in 2022. Welcome to the stage, moderator Dr. Monica McElmore.
We doing an Oprah thing? Wow. Hi, everybody. It's so good to see y'all. Oh, my goodness. I'm so excited to be here. So a couple of things. Hi to all the digital folks. I've been watching you live tweeting and doing Instagram. I'm very grateful to be here. You know, my sister from another Mr., Dr. Ndidi, you know, we the Trenton people represent. And so thank you so much for building infrastructure and talking to me on Thanksgiving of last year so I can make sure that this could be on my calendar so I could actually come. Because I have watched virtually this conference, I know at least for the last 2 years, because I've been double or triple booked. So the idea that I could actually be here, especially on a panel called Disruptors with the people that I'm going to get a chance to talk to, I'm super excited. So I know all of them personally. I am going to read the bio, but I'm going to embellish because I know all of them. So our first panelist is Dr. Nakia Grayson, and I'm really glad she took me off punishment last night because, you know, it's all love. She's a reproductive justice informed public health activist, anthropologist, and family nurse midwife who has devoted her life to serving and empowering people in underserved communities. And Dr. Grayson is the Chief Clinical Officer at Choices Center for Reproductive Health, and if you've never been there, oh my goodness, it's just one of the most incredible places in the world, and they have built such incredible infrastructure there. I highly recommend it, but don't overwhelm them because, you know, they'd be busy. Where they opened the first nonprofit comprehensive reproductive health center in the country, the first birth center in Memphis, and it is the first site for the Black Midwifery Fellowship. So, Dr. Grayson, come on down. I'm a big fan, big fan. The second panelist I'd like to invite to come on down, y'all know her, y'all love her. You've already seen her today, is my other sister from another Mr., Dr. Michelle Drew. Dr. Drew is a certified nurse midwife, a family nurse practitioner, and the founder and executive director of Ubuntu Black Family Health Collective, which we heard about this morning, which is a community-based organization that serves as a social safety net in Wilmington, Delaware. She is a first-generation college graduate, but a 10th-generation midwife with a documented ancestry of midwives back to her 7th great-grandmother, Sarah, a free Black woman in Surry County, Virginia. For those of you following me on social media, you also know she's my roommate and one of my closest confidants anywhere I travel. So thank you for coming down, Dr. Drew. Our third panelist is Mama Jeannie Joseph. Let's give it up for Mama Jeannie Joseph. Time Woman of the Year. Time Woman of the Year. Let's go. Jeannie, exactly, right? British trained midwife who fights to ensure every person has their healthiest possible pregnancy, birth, and postpartum experience with dignity and support. Mama Jeannie, I can't call her by her first name, out of respect. Mama Jeannie created the JJ Way, which is an evidence-based maternity care model delivering readily accessible, patient-centered, culturally congruent care to women in areas that she terms maternal toxic zones, and she's been holding it down in Florida. Love you. And then we're going to welcome back to the stage someone who I tapped to be part of my advisory committee for the newly renamed Manning Price Spratlin Center for Anti-Racism and Equity, or what we call CARE in Nursing Center at the University of Washington. And if you don't know Frankie Manning and Lois Spratlin, you need to know who those two black nurses were, and because we stand on their shoulders. Anyway, Dr. Lucinda Canty. Let's give it up for Dr. Canty again, our opening keynote speaker. Is a certified nurse midwife and an associate professor of nursing and the director of the Seeds Work Health Equity in Nursing program at the University of Massachusetts at Amherst. And she received her BSN from Columbia University, her MSN from Yale University, specializing in nurse midwifery, and her PhD from the University of Connecticut. Her research interests include the prevention of maternal mortality and severe maternal morbidity, reducing racial and ethnic health disparities in reproductive health, promoting diversity in nursing, and eliminating racism in nursing and midwifery. I also know her incredible work with the National Commission to Address Racism in Nursing with the American Nurses Association. So let's give it up for like the excellence in black midwifery. So when I say things like, you know, I'm midwife adjacent, that's what I mean, because people know I'm not trained in midwifery, but I hang out with these four often. So that's it. This panel is called Disrupting the System, Addressing the Broken Medical Structure Impacting Black Birthing People. And it was purposefully and effectively and affectionately entitled this because each of you have taken it upon yourselves to disrupt the status quo and to really challenge our clinical systems. So I want you all to think about this. I'm going to start with Dr. Grayson, though. Exactly. What personally motivated, you know, your level of activism? And if you can, you know, how do you manage to train and practice in institutions that have, like, cultures of racism and anti-blackness?
Yeah, okay, so what... I can't even look at Monica. What led me to this, right? Okay, so first of all, I think that I grew up in a space where we were taught to speak up for people, right, and to care for the least of these. Then I went to Howard University, and I think that we teach Protest 101 and orientation, right? If you ever been to chapel, you know, they all come through there. Hey, we're meeting at such and such to protest X, Y, and Z. I mean, that was every Sunday. So, I mean, I think that fire, was always there, but I think that what led me to the work, well, I know that what led me to the work was, when I was doing some work as an anthropologist. I'm an applied anthropologist as well, and, was working on a project evaluating the March of Dimes. One of their programs, and interviewing families, and these families talked about infant loss that they had experienced, and it was generational, and they could not understand what had happened. And so it really led me down a path to really trying to figure out what happened. And a lot of them talked about their bodies being broken or feeling like they were not cared for properly by the medical system, or that they weren't listened to. And then I started interviewing older black women in the community, and they talked about these midwives that they were cared for by. And I was like, where are the midwives? I mean, there were none in our community. And so, as I started to do more research, especially around Black midwifery, I felt called to reclaim that space for us and to see not only a reclamation, but a restoration of us in our community. And so I decided to answer the call, as they say, and step into that space and become a midwife. And, you know, we were talking about this, Carrie Stewart and I were talking about this earlier, how we kind of came into this as a second, because this was like a second or maybe even a third career for me. And how our younger kids are not really coming into this because they don't know that this is an option. So it was really important to me to open the door and to really hit the ground running so that they did know it was an option and just bring as many of them with me as I could. So, yeah.
Appreciate you. Dr. Drew, what has motivated this level of activism? And, what's personally motivated this level of activism?
Personally, well, I mean, I came by it honest. I am Mabel Drew's daughter, Viola P. Henry's granddaughter, and they never saw an issue they wouldn't take on. I used to love when teachers would be like, Miss Drew, do I need to call your mother? Oh, yes, please. Because when the woman who's like 6 feet before her afro showed up in a black turtleneck and jeans and black leather boots, and there were a bunch of, motorcycle riding Black Panthers in the parking lot, it was like, this was not going to end how you thought it was. And you said something, and the question talks about, a system that's broken. But the system isn't broken. The system is working exactly how it was intended. Yes. And so, I decided early to, not try to fit in because there's no way. I am loud. I am Black. I am unapologetic in believing that this country was built on the backs of Black folks, on land that was fed by Indigenous people's blood. We don't owe anybody an apology. So I will earn your respect or not if you choose not to give it, but what I'm not going to do is back down in any fight, and especially in a fight that's killing our community and destroying not just our health, but our culture, and doing it at a big profit.
Thank you for that, Mama Jenny.
Yeah, I think my story is so inextricably tied into physically, geographically being here. I was called to midwifery since I was a little young kid. At 16, I knew I was going to be a midwife and not a nurse. At 19, I got into midwifery training in a hospital-based environment and became a midwife at 21. And I have been in midwifery my entire adult life. But I've spent 32 years of midwifery in the United States. And from the day I got off the plane, because I didn't do not a scrap of research, just like, oh my gosh, I'm going to America. I'm going to marry this gorgeous Black man and it's all going to be lovely. So that will teach me, right? Because when I got here, first thing I found out was, well, what are you talking about, midwife? We don't even know no, we don't do that. That's old, and that's not the way. So it took me a minute to readjust to that, but I started working with an OB because it was a Canadian OB, a white Canadian man who knew what a midwife could do, put me in his office and said, you can't go to the hospital, but stay in this back office here and you can work with me. Within a year, and I came with endometriosis. I had had it my whole adult life, and I'd had lots of treatments and lots of problems, but within a year, I lost my uterus and both ovaries. I was 30 years old. Because I had no clue. That's why. And that opened up for me what I now understand full well, and I'm just sick even to this day. 1989 to today, I am furious that this is going on in plain sight. And like Michelle said, it is on purpose, and it will prevail. Because what we're talking about is justice. This is not about medicine. This is about power. And this is what has me so worn out and overwhelmed and yet can't stop because we must fight. And that's how I got to do what I'm doing. And you see all these wonderfully, beautifully credentialed folk right here. I don't have a piece of paper. I am a midwife. I'm not a nurse. I'm not an academician. I have not been to college. I have just done that one thing. And that has led me to this space right now to be able to sit here and talk with you all. And the disruption that I'm up to is no more. Every person, every time, as a human right, deserves to have respect, dignity, and autonomy, just because.
Yes, let's do this. Dr. Canty.
And I think that I have that same anger. And for a long time, I was silent because I used to believe anything that people told me. Even when I felt it wasn't quite right, I believed it. And when I started talking with Black women, learning their experiences, learning the trauma that they experienced, I was like, I'm not going to be silent anymore. And then